we will be talking about what's a normal gait, what is limping, approach to the limping, some of the differential diagnosis and some pathological causes of limping. Limping is not a diagnosis, it is an uneven, jerky or laborious gait. It is caused due to pain, weakness, structural or mechanical abnormalities.
Most importantly,
From
pain is not there, weakness is not there, structural defect is not there, mechanical abnormalities is not there. Still, the child is limping. It's an adolescent girl
function.
That causes problems. And that's not that unknown.
The normal gait cycle consists of two phases. The gait cycle means the sequence of limb during walking. It is having two phases. The main phase is stance phase. It consists of 60% of the phase. That is the period of weight bearing. And the second one is the swing phase. It is the 40% of the gait cycle. It is the non-weight bearing period. Normal variations of gait in children. Toe walking is common up to 3 years. In toeing between 3 to 8 years, it is most commonly due to persistent femoral anteversion. Flat feet are common and usually resolved by the age of 6 years. Crooked toes mostly resolved with weight bearing.
Toe walking is common, but it may be an early marker for autism or type mechanism. So these are the three causes of toe walking. It might be a normal, it might be autism. Because they are very sensitive, so they don't want to take the full sensation. They will the toe. So don't say when a toe walking, don't say, oh that's never say that. Keep an eye, ask for the symptoms of autism, socialization, and look at the tendinocheitis, whether it is tight or not.
Adult pattern of gait develops between 3 to 5 years of age. The key points: most children presenting with limp do not require any investigations. Observing the child's gait may help localize the problem and narrow the differential diagnosis. Acute inability to walk or weight bear is a red flag sign. Septic arthritis is an orthopedic emergency and should be considered in all limping children with severe localized joint pain and fever. Transient synovitis, acute myositis, and minor trauma are the most common causes of limp in children. Pain causing limp can be referred, so thorough assessment of the joints above and below, including the spine, is essential to accurately localize the source. History. In history, we have to initially ask the age. The importance of age is child less than 3 years. Septic arthritis is more common in this group. Sex of the child. Developmental dislocation of hip is more common in female child and on the left side. Duration, the progression, whether it is improving or aggravating with activity should be asked, because if it is aggravating with activity, it is more towards traction apophysitis like Osgood-Schlatter's Sever's disease. And we should also ask at which time it becomes worse, the limping. If it is getting worse in early morning and associated with morning stiffness, it is a pointer of juvenile idiopathic arthritis. If it is increasing in night, that is nocturnal with pain, it could be a marker of osteoid osteoma and other neoplasms. Also, we should inquire whether it is painful or painless, and also try to localize the location of the pain. If it is painful, it is more in favor of infection, inflammatory, trauma or tumor, and painless is more in favor of developmental dislocation hip, neuromuscular causes, lower limb length discrepancy, etc. The history of trauma, new or increasing sport activity should also be inquired. Because repeated injury at a site due to traction will cause and result in traction apophysitis. We should also ask about the associated symptoms like fever, weight loss, anorexia, and voiding problems. Fever is more in favor of septic arthritis. The weight loss and anorexia are in favor of malignancies, and voiding problems are usually seen with neurological disorders. History of recent dysentery should be asked. Then we have to suspect Reiter syndrome. History of recent viral infection or streptococcal infection should also be inquired. Then it could be a suggestive of post-infectious arthritis. History of upper respiratory tract infection may suggest transient synovitis. Recent intramuscular injection of any vaccination should also be asked, because it can cause transient limping due to muscle inflammation or sterile abscess. The past medical and surgical histories should also be inquired, because meningomyelocele surgery, etc., will give a clue towards the neurological disorders. Immunization history should also be asked, whether the child is properly immunized or not. Polio, even though it is rare now, is also a cause of limping. The developmental history should be taken in broad to assess whether there is having any developmental milestone delay, like autism or any cerebral palsy. Family history of rheumatological or neuromuscular or connective tissue disorder should also be inquired. Red flag signs in the history. Children less than 3 years, if it is presenting with limping, the diagnosis of septic arthritis should be kept in mind if it is presenting along with fever. Sudden inability to bear weight is also another red flag sign. Fever or systemic illness should also be kept in mind. More than 9 years, child presenting with hip pain or restricted hip movements, the split capital femoral epiphysis should be a TED. On examination, generalized wasting, pallor, the interaction with caregiver, all should be considered. We should map the temperature, the assess gait if it is possible. We should assess the gait by asking the child to walk and, if possible, running. Joint examination is done in 3 phases: look, feel, and move, including the joints above and below the area of pain. Observe the gait and record it for analysis to decide for the type of abnormal gait. Look. In look, we have to assess the resting limb position, whether the joint is alignment is correct or not. For any leg length disparity, any swelling is present or not, any deformity, the skin changes. Skin changes include a rash, wound, bruise, erythema, pallor. All these bruise, erythema, pallor are suggestive of hematological disorders like hemophilia, which can result in hemarthrosis and cause limping in the child. The feel, the skin temperature, tenderness of the bone and soft tissue, the crepitus, fluctuations, all should be assessed. In movement, we should have to look for any limitation of the joint movement. It is assessed in 2 ways: active movement and passive movement. Active movement can be facilitated by placing a toy and asking the child to take it, or the parent should be out of reach. In passive, we have to assess for the limitation and asymmetry in all planes of motion, and we have to compare both sides. Marked reduction in range of motion is suggestive more of serious pathology such as septic arthritis. Also, we have to assess the tone, power, and reflexes to assess the neuromuscular functioning, and neurovascular assessment of the affected limb also should be done. Abdomen, scrotum, and back or spine should be assessed, because pathologies like appendicitis Torsion testis can also result in severe pain and can cause limping in a child. Petechiae purpura ecchymosis should be looked for getting the clue towards henochondrin purpura malignancy or the hematological causes. The limb length measurement should be done. It can be done by either the visual method. We can assess whether both the limbs are of the same length, or using the tape measurement. Physical examination, we should be assessing the child in the standing position. Look at back should be examined for scoliosis, local tenderness, and to assess the range of motion. Measurement of the thigh and calf circumference should be done for looking at atrophy. If more than 1 to 2 centimeter difference is present between the two sides, that is affected, and normal side, it suggests an atrophy of the affected side. Examination in supine position. We have to look for the swelling and tenderness and check for the range of motions. In supine position, we will check for the limb length discrepancy. In this examination, we should the short leg must be differentiated from apparent shortening that is caused by scoliosis or joint contracture in this step. Common differential diagnosis of a child presenting with limping. In toddlers, that is 0 to 4 years of age, transient hip synovitis can be caused. Acute myositis, toddler's fracture, developmental dislocation hip, septic arthritis, and non-accidental injury are the common causes. The uncommon ones are malignancies like leukemia, neuroblastoma, and the metastasis. Child of age 5 to 10, transient hip synovitis, acute myositis, developmental dislocation. Also, Perthes disease is another diagnosis. The uncommon ones are leukemia and Ewing sarcoma.
Always those the common ones, but in your profession, you pick for the uncommon ones, because the uncommon ones are much more worse, and you cannot afford to mix. You get the point. See, if you acute myositis, it will get cured. Toddler fracture, it's not going to be killing disease. You didn't, you mentioned about non-accidental injury. Septic arthritis will give you enough signs that the infection is there. But what you can miss is the leukemia and the neuroblastoma. At that age, neuroblastoma, what should be very careful. Will not give you any signs other than the leukemia. And osteoid osteoma, yesterday's X-ray that I showed you, I did the MRI and it came out to be osteoid. I'll show you the MRI next week.
In adolescents more than 10 years of age, the common causes are stress fractures and sprain, traction apophysitis like osteoarthritis, Sever's disease, and slipped upper femoral epiphysis. The uncommon ones are osteoid osteoma, osteosarcoma, and leukemia. Children of all ages, the causes are infections, mostly osteomyelitis or septic arthritis, bursitis, discitis associated with it, tuberculosis, trauma, non-accidental injuries, malignancy, the hematological and bone soft tissue malignancies, rheumato-immunological like henochondrin purpura, vasculitis, reactive arthritis, post-infectious arthritis, and Guillain-Barré syndrome. Intra-abdominal pathologies or genitourinary conditions should also be kept in mind, like appendicitis, testicular, and ovarian torsions. Hematological include vaso-occlusive crisis in sickle cell anemia, hemophilia. Investigations: CBC, ESR, and CRP, if they are raised, suggest inflammatory or infective picture. Imaging, X-ray, pelvis AP or frog leg view is usually done to assess the developmental dislocation hip, Perthes disease, and flipped upper femoral epiphysis. Normal X-ray do not exclude septic arthritis and osteomyelitis. Ultrasonography of the hip is done to assess the drainable effusion in case of septic arthritis. Blood culture will yield evidence in septic arthritis and osteomyelitis. The peripheral blood smear should also be done to rule out leukemia and other malignancies. Manto and CBNAT for tuberculosis assessment. Coagulation profile should be done to assess the hemarthrosis.
Some examiners are very fussy. Have all these minor things. Yes.
For immunological, we will do ANA assessment and rheumatoid factor, renal function test and endocrine screening. Renal function test and endocrine screening should be done for in case of
Rheumatoid factor positive polyarthritis. Take a look at the ANA positive now.
Spinal fluid analysis is done in case.
What you don't do in pediatric practice or your practice is the anti-CCP. And I've seen many pediatricians, they do anti-CCP because what has happened, some adult rheumatologists have done, and so they follow it to the concept. So they do anti-CCP.
Management of limping child. If the child presents with a limp, detailed history plus examination should be done. It should be done pre and post analgesia, and isolate the affected area. The region above and below should be region above and below the pain should be assessed, and we should identify the red flag signs. Red flag signs on history, examination, or investigation are acute onset, severe localized joint pain, concern of inflicted injury, that is non-accidental injury, persistent limping more than 7 days, nocturnal symptoms associated with suggestive of malignancies, suspicion for malignancy, the systemic symptoms including fever, weight loss, petechia or purpura. These are the red flag signs. If red flag signs are present and walking the child with mild or no discomfort after simple analgesia, then it is likely a transient synovitis or minor musculoskeletal injuries. We can consider for conservative management in this case and arrange for review after 3 to 5 days. If it is the other way around and child is having more discomfort after the analgesics, the features of septic arthritis should be looked for. That is acute severe joint pain or inability to weight bear or fever and systemic signs. If these are present, urgent orthopedic consultation, blood sample should be sent for all investigations, and ultrasound and antibiotics or surgery should be considered. If there is abnormality found on imaging and associated with the clinical findings, we should think of fracture, Perthes disease, slip upper femoral epiphysis or mass lesion, and these should be managed accordingly. Concern for infectious, if there is concern for infective cause, then blood culture should be done, and in case of abnormal result, orthopedic consultation plus paid pediatric treatment should be given. Some of the pathologies, orthopedic pathologies causing limping. Toothless fracture, it is an oblique fracture of the distal tibia without fibular fracture. The treatment is splintering. Slip capital femoral epiphysis. The risk factor associated with this condition is obesity, age between 10 to 16 years, and endocrine disorders. In this condition, there is a pain in the groin, limping.
I think steroid use. Steroid use, adolescents, overweight, Gaucher disease. Gaucher
necrosis growth hormone excess the name has been changed to slit upofemoral. Okay. Sinus and Gaucher is more than necrosis.
Transient synovitis and septic arthritis differentiation. Transient synovitis is The cause is unknown. It, usually presents after a viral illness or hypersensitivity, while septic arthritis is of infectious cause. Age group of transient synovitis is 3 to 8 years, and that of septic arthritis can present in any age. Transient synovitis is a diagnosis of exclusion, while septic arthritis can be diagnosed by synovial fluid aspiration. X-ray is normal and USG may show effusion in case of transient synovitis, while in case of septic arthritis, X-ray is insensitive and ultrasound gives joint effusion. Treatment in case of transient synovitis is bed rest and minimal weight bearing and NSAIDs. Septic arthritis treatment is bed rest, splinting, antibiotics, and if needed, surgery should be considered. Some of the gait abnormalities. This is a person having antalgic gait, where he is normally in the gait cycle, major portion, that is 60% is on stance, that is weight bearing phase. But in antalgic gait, the person is unable to weight bear on the limb, so he is walking. The stance phase is decreased. This is known as short stance case or antalgic gait.
Two common causes in children is severe constipation. Severe constipation. Actapa, left side direction. And other is ill-fitting shoe. Because the loaded rectum, ill-fitting shoe. Ill-fitting shoe.
Child with a hemiplegic gait, you can see that the left side upper limb, that the child is not moving while walking. Normally,
It should be painful.
So you said stance phase for 20%, you said stance phase and swing phase.
stand phase is 60% and swing phase is 40%. This is the trundle gait, where the pelvis is tilted and it sinks to the normal side. Because in normal stance, the gluteus medius muscle is contracting and keeps the pelvis from sinking to the opposite side. But here in Trendelenburg gait, the adductors and gluteus medius is not working, so the pelvis is sinking to the contralateral side.
Which side is the
Left. This is the high stepping gait. It is usually associated with foot drop and neurological.